Good evening, everyone. Once again, a warm welcome to you all for our day 4 session. So today we are going to see about ventilation strategies. So today we will have 3 talks. The first one on air-based ventilation, and second one on COPD ventilation, and third one on HFNs and its applications. This last talk was supposed to be on Tuesday, which was swapped due to unforeseen circumstances. So moving on to today's first talk, I invite Dr. Charan, Lakshmikant Charan sir, from Royal Care Hospital, Coimbatore. And a few words about him. He did his undergraduation from PS Institute of Medical Sciences and post-graduation MD Anesthesia from Kasturiba Medical College. Later, he completed IDCCM from Sundara Medical Foundation, and he also finished successfully EDIC and EDAC. And he is currently working as cancer intensivist at Royal Care Hospital. And his special interests are sepsis, ARDS, ECMO, and teaching the young intensivists and doing research activities. Welcome, Dr. Charan sir. Over to you, Charan sir, on ARDS ventilation. Thank you.
Thank you, Nishant, for your introduction. Okay, good evening, everyone. As we are going through this mechanical ventilation talks with this SIP conference, I'll be talking about the ventilatory management of ARDS today. So to start with, I would like to acknowledge my teacher, Dr. Ravi Rajagopalan, for all the education that he has given me. My chief, Dr. Yaman Shivakumar, who has been a guidance for throughout, and the organizing committee, including Dr. Nishant of SIP, for giving this opportunity to present in front of you. So the objective of my talk for the next 20 to 30 minutes would be to tell you about the alteration in physiology, what happens in the ARDS, the differences in the flow and airway pressures due to this altered physiology in ARDS, and because of the changes in flow and pressure, what are all the consequences that happens, and what are the challenges that we face in ventilating them, and how to ventilate them successfully with minimal problems. So first, I would like to start with some few slides on pathophysiology of ARDS. This is very important for us to know how to ventilate these patients. As we all know, ARDS is nothing but a type of an inflammatory disorder. It has an episode like either a pulmonary event or an extrapulmonary event, which initiates a cascade of inflammatory events. And as a result of this inflammatory cascade, what happens is there is a break in the both epithelium of your alveoli and endothelium of your pulmonary capillaries, thereby causing more and more release of proteinaceous protein-rich exudate into the interstitial space as well as into the alveolar space. As I told you, it is a syndrome of inflammation. What happens is there is a diffuse alveolar epithelial damage. If it is a pulmonary etiology, what happens is that etiology as per se in the lungs, like your pneumonia or aspiration or drowning or a lung contusion, whatever happens, it causes an alveolar epithelial damage. Because of this alveolar epithelial damage, what happens is there is a cycle of inflammatory cascade, and this not only happens in the alveolar epithelium, but it also gets into the endothelium of the pulmonary capillaries. And this causes a breakdown of the endothelial barrier in the pulmonary capillaries, and there is leak of your protein-rich edema fluid. And this, when the epithelial damage is happening, because of the entry of this edema fluid into the alveolus gets flooded. More and more of this alveolus getting flooded with these fluids, these alveoli will not be useful in oxygenating the patient. So more and more lung unit getting involved in this ARDS, more and more of oxygenation problem will be faced by us. So there are two basic mechanisms by which oxygenation problem happens. One is because of the flooding of the alveoli, and the other is because of the alveolar collapse. The alveoli collapses predominantly in the posterior or the dorsal portion of your lung. These two things make less alveolus involved in oxygenation, more amount of shunt causing oxygenation problem. So the main aim for us during ventilation of these patients is to tackle this problem and improve the oxygenation in these patients. So some of the few pressures and other things that we need to know before going into the ventilatory managements, I would like just to touch upon all these things. Most of them would have been taught to you in the classes, in the previous 2 or 3 days of classes. I don't want to bore you much with the physiology, but these things are very important. As we know, ventilator is nothing but a machine that generates pressure which is necessary to cause a flow of gas into the alveoli and increases the volume of lungs. Our aim is to improve the volume of lung, tidal volume to be pushed into the alveolus. Only when the tidal volume is pushed into the alveolus, it takes part in oxygenation, it takes part in dissociation of oxygen into the blood capillaries, and it oxygenates the patient. For this volume of gas to go into the alveoli, it needs a flow of gas, and that flow of gas needs a pressure gradient. That generation of pressure gradient is what is being done by the ventilator. So ventilator is nothing but a machine which generates this pressure gradient. So in order to create this pressure, what it needs is it needs two important components of the lung, which is your resistance and compliance. These two are most important components of your lung function. Whenever there is a problem with your resistance or a compliance, there is always a problem with your oxygenation. As we all know, resistance is nothing but the amount of work that the flow has, the flow of oxygen through the airway. Whenever there is more resistance to the flow, there is problem. And compliance is predominantly a problem at your distal airway, that is at the level of your alveolus. So resistance is at the level of your airway, and compliance is a problem that happens at the level of your alveolus or the distal part where your oxygenation takes place. Both increase in resistance as well as a reduced in compliance, both of them causes an increase in your work of breathing. This increase in work of breathing, as it worsens, patient gets into respiratory fatigue and failure. And this is the stage when usually the patient comes to your ICU. When the patient comes in to ICU with your respiratory fatigue and failure, we always put them on a mechanical ventilation, and mechanical ventilator offloads this work of respiratory muscles. Though it offloads the work of respiratory muscles, it still has to work with the lung of the patient. Whatever problem, whatever pathology that the lung has been affected with, that causes the problem with your compliance and resistance in the lungs. And this ventilator has to work against all this pathophysiology. So in the ARDS, what happens is predominantly it is a compliance. As we know, the asthma, COPD, and other obstructive airway diseases, problem is predominantly with your resistance, whereas in the ARDS, problem is predominantly with your compliance. Compliance reduces in ARDS. What is compliance? Compliance is nothing but a amount of pressure needed to improve the volume in your lung. The change in pressure to the change in volume. More amount of pressure change needed to produce the same amount of tidal volume, it means the compliance is worsened. To produce the same tidal volume, if the amount of pressure change that is required is less, means the compliance is better. So whenever there is a problem with your compliance, the ventilator as well needs to increase its pressure delivery to improve the volume. So these are the two pressures. I think they would have been dealt with yesterday. The peak inspiratory pressure, which predominantly shows you the pressure in the airway, which is not very important for us. What is very important for us is your plateau pressure. Plateau pressure is the pressure at the level of your alveolus. What is important is this plateau pressure should not go up. If this plateau pressure goes up, it can cause injury to your alveolus. So this is more important for us. As you can see in the resistance diseases, what happens? Your peak pressure increases, but your plateau pressure remains the same. Whereas problem like ARDS, which has a decreased compliance, your plateau pressure increases. This is the problem that we are more concerned about. So when you come to ventilate a patient with ARDS, what are our goals? The first most important goal is to treat the primary cause, because ARDS per se is not a disease, it is a syndrome. It is being caused by a disease or a condition in the lung or outside the lung. That primary cause is what is creating this syndrome. So whatever you ventilate the patient, it is only going to buy you more time for that inflammatory cascade or for that syndrome to settle down. What it will settle down only when the primary cause, whether it is a pneumonia or it is a something like a lung contusion or pancreatitis or some other sepsis in some other part of the body, whatever it is, that has to be treated with. Unless you treat the primary cause, your ventilation alone will not treat the ARDS. At the same time, what is being done by the ventilator is to improve the oxygenation. It buys you more time. It provides oxygenation to the patient till the lung improves. So in order to improve the oxygenation, it has to compensate for the problem with your resistance and complaints. And in due process, what happens? There is something called as ventilator-induced lung injury. This is very, very important. As we all know, in our medical practice, the most important thing for us is we should not do any harm. Even though if you do any good or not to the patient, the most important thing is you should not do any harm. Any treatment or any drug that you use in medical fraternity, it has its own side effects. You should try to avoid those side effects. What is the side effect that happens along with this ventilatory management in any patients, not only in ARDS or in any patients, is called as ventilator-induced lung injury. I think this would have been covered by Dr. Bala on the first day. It predominantly has your polytrauma, biotrauma, atelectrauma, and barotrauma. Polytrauma, as we all know, because of the excessive volume, it causes overdistension and damage to your alveolus. Barotrauma is nothing but a high pressure to your alveoli, which again causes disruption of your alveolar epithelium or damage to your alveolus. Atelectrauma is nothing but the trauma that happens to your alveolus because of the repeated closure and opening of your alveolus. Because of the repeated closure and alveolus, it causes some amount of shearing force and damage to your alveolus, as well as increase in your inflammatory release. The fourth one is your biotrauma, which is the release of your inflammatory mediators because of the ventilation. So polytrauma, atelectrauma, barotrauma, biotrauma, all these things can worsen the ARDS as such, and it can cause ventilator-induced lung injury. So our main aim in the ARDS ventilation is to improve oxygenation, but at the same time not cause ventilator-induced lung injury or worsen the ventilator-induced lung injury. So how do we do it? We'll just see it in the coming slides. So when they started studying on these ARDS patients earlier in 1980s and 70s, the predominant of these studies were done by Gattinoni et al. And what they found out was this is not a homogeneous disease. It does not affect all the part of lungs uniformly. What happens is it predominantly affects the dorsal portion or the posterior portion of your lung. As the patient lies supine, this is your posterior or the dorsal dependent portion of the lung, which is affected more. That is, there is more amount of collapse or more amount of alveolar flooding in the posterior portion. Whereas the anterior portion or the ventral portion of the lungs is relatively spared. That is, more amount of normal lung is preserved in the anterior portion and more amount of dependent collapse and alveolar edema and the ARDS happens in your posterior portion of your lungs. The importance of this is that is when the concept of baby lung came. As you all know, the normal adult tidal volume, we usually give it around 8 to 10 ml per kg of tidal volume. That is for an adult, it will be around 500 to 600 ml. Whereas for a baby, the same 6 to 8 ml per kg will be coming around only to 50 to 100 ml. In a patient, in an adult patient who has a ARDS, what happens is the amount of lung which is being aerated or the amount of lung that takes part in the ventilation or the amount of lung in which the total tidal volume that you deliver is going to be supplied is very, very small. This amount of lung will hold only to a amount of lung that is there in a baby or a child who is 5 to 6 years. When you are giving the same amount of tidal volume with the same amount of pressure as you are giving to an adult who has a whole lung preserved, this amount of normal lung is going to take the brunt. And whatever injury that is going to happen because of that tidal volume and pressure is going to worsen the normal portion of the lung. Already 50 to 60% of the lung is affected. Whatever normal portion of lung is there, it is going to take the brunt of whatever tidal volume and pressure you are going to generate, and that is also going to get affected. This is the concept of baby lung. In an ARDS patient, the amount of lung or the amount of portion of lung that is preserved or the portion of lung that is taking part in the ventilation is going to be very, very small, almost equal to the lung of a baby. That has to be taken into consideration. So ARDS is nothing but a heterogeneous disease. Lung is not only stiff, but it is also small. So the normal aerated segment will inflate easily, even with the low pressure and tidal volume. So whatever tidal volume and pressure you are going to deliver, it is going to go into the place where there is a least resistance, or which has a which requires only a small amount of pressure. Whereas this non-aerated portion is going to require a lot of pressure for it to be opened. So this will not be predominantly opened. So what happens in a normal lung, whatever tidal volume you deliver is going to be equally distributed to all the alveoli. Whereas in a ARDS or baby lung, as we saw in the previous slide, whatever tidal volume you are going to give relatively goes into the normal alveoli. The fluid-filled alveoli or the fluid edema-filled alveolus, there is not going to be any aeration. Air is not going to enter into it. And also the portion of lung that is collapsed, or the atelectatic alveoli. This again is not going to be aerated normally, and most of the air is going to go only into this normal alveoli, and this is going to cause more injury. So the normal lung segments are small, and it depends on the severity of ARDS. More severity of ARDS, less is going to be your normal lung. It's like a baby's lung, and maybe overinflated when ventilated with a traditional tidal volume, and it needs to be handled gently. So this is the main reason why patient gets into volume trauma. As you would have seen in the previous talks yesterday and day before yesterday, this is your pressure volume curve. This is the normal pressure volume curve in a normal lung. Whereas in the ARDS patient, what happens? It goes to your right. That means there is more pressure needed to generate less tidal volume. That is, your compliance is decreased. Your compliance is affected. It requires more pressure to generate the tidal volume. Whereas in the normal lung, it requires less pressure to generate the tidal volume. So this is a lung with the ARDS. Here what happens? This is a part which represents your over-distended lung. Your lungs get over-distended. This is the portion where there is predominant collapsed lung. So this is your collapsed lung, and this is your over-distended lung. We try to ventilate the patient in between these two. But what happens? Most of the time, air enters into your normal alveoli, and the zone of over-distension increases. And because of this over-distension, there is problem with your volume drop. So when they recovered from ARDS in 2001, the Gattinoni did a study. He did a CT to all these patients who developed, who improved from ARDS, and what he found out was predominantly anterior portion of the lungs, or the ventral portion of your lungs, when in the recovered patient had reticular pattern or non-dependent pulling. This is mainly because of your volume trauma that has happened to these lungs when they had a ARDS, and they were ventilated for ARDS, when predominant of your tidal volume is going into your normal anterior portion of your lung. This is evidence for the volume trauma that happens during ARDS ventilation. Next comes the barotrauma. Barotrauma, as we know, it is predominantly because of your pressure. As we saw earlier, there are two types of pressure, and the most important pressure that we are talking about is plateau pressure. Plateau pressure is most predictive of lung injury. The goal of plateau pressure that we are aiming in any ventilation, especially in ARDS ventilation, is less than 30 centimeters of water. The lower the plateau pressure, better is the outcome. But still, this 30 is only an arbitrary number, which has been identified after a lot of studies. Doesn't mean that 28 is good and 32 is very bad. But whatever plateau pressure, we try to keep it less than 30 and as low as possible. It decreases the alveolar over-distension and reduces the risk of lung strain. It adjusts the tidal volume. We need to adjust tidal volume to ensure a plateau pressure of hold. There are certain patient groups in whom you can accept a slightly higher plateau pressure. They are patients who are very obese, pregnant patient, or patient with a severe ascites, where there is a lot of pressure from your abdominal compartment into your lung. Those patients, you can accept a plateau pressure of slightly more than 30 up to 32 to 34. But other than these patients, it is always better to maintain a planetary pressure of less than 30 to avoid barotrauma. So polytrauma and barotrauma we just dealt with. So how to ventilate the patient without polytrauma and barotrauma. This is called as lung protective ventilation. What are the strategies in the lung protective ventilation? So the best thing to avoid all this ventilator-induced lung injury is to avoid ventilation. So there were a lot of discussions on how to avoid ventilation in these patients, and there were a lot of interest on this usage of non-invasive ventilator. As we all know, non-invasive ventilator are being used in many even peripheral setups nowadays in almost in the wards and the ERs, not only in the ICUs. So they started using NIV for ARDS. As we all know, the main evidence of usage of NIV is only for a type 2 respiratory failure or your COPD. There is no evidence for a type 1 respiratory failure or a hypoxemic respiratory failure. So they started doing some small studies. In the initial small RCT, when they compared Venturi mask with NIV, there was an improvement in oxygenation and lower rates of intubation. But still later, when they did a larger studies and they did an analysis of your lung safe study, they found out that NIV, when used in severe ARDS, can be an independent predictor of mortality. So it should not be used in a severe ARDS. And in a prospective study, a large prospective study, again, they found out that the ARDS in which the etiology is pulmonary, such as pulmonary edema or pneumonia or lung contusion or aspiration, in those pulmonary etiology for ARDS, the improvement is going to be less and the mortality is going to be high. So if at all you're going to use, you can use it in patients with the ARDS because of an extrapulmonary etiology. So where are the situations in which we can use NIV? It can be reserved for occasional patients with mild ARDS, hemodynamically stable, who are easily oxygenated and does not need immediate intubation, and there are no absolute contraindications of NIV, such as your poor airway reflexes or a low GCS and other absolute contraindications. So all those things are there, not there, you can try NIV. But the note of caution is that it has to be used for selected individuals, mild ARDS, under close supervision in ICU. Anytime, if in doubt, intubate immediately. Do not prolong on NIV in a patient with ARDS. Who are getting ventilated after prolonged usage of NIV, definitely their mortality is going to be high. So the next thing is, once you ventilate this patient, once you intubate this patient, how are you going to ventilate this patient? The first thing that comes to our mind is, what is the mode of ventilation? Is there any mode which is superior to the other? So the predominant two modes that we always talk about are volume controlled and pressure controlled. As we all know, volume control guarantees your tidal volume. It avoids polytrauma. But the disadvantage is it doesn't guarantee your airway pressures. So barotrauma can happen. In a pressure controlled ventilation, advantages, pressure can be controlled, barotrauma is avoided, but disadvantages, volume, tidal volume is not controlled and it can cause volume trauma. So both has advantages and disadvantages, and it is found that there is no difference between these two modes. Whichever you are comfortable and confident in using, you can go ahead with using it. But whatever mode you are using, use the mode and control both the variables as much as possible. If it is volume control mode, your volume is controlled. Try to keep a close watch on the pressures. If it is a pressure control mode, pressure is being monitored. Keep a close watch on your tidal. Both has to be monitored carefully. There was a study recently which has given a good mortality benefit or a good benefit with a mode called airway pressure release ventilation. This is a mode which is found to have a significant increase in the number of ventilator-free days and significant improvement in ventilation. This is a newer mode. It is not a mode that is being used by everyone. It is not a mode that is there in all the ventilators. But still, these are studies which are done in Western countries, and in one of these studies, this mode is found to be useful. But there was no difference in mortality. If you ask me whether this mode has to be used, if you have a ventilator which has this APRV mode And if you are confident in using it, if you're comfortable in using it, you can use. But buying a ventilator just because you want to have a APRV mode in your ICU, I'm not very sure about it. So what is basically done in the APRV mode is there are two levels of ventilation. Ventilation is being done at the higher pressure and the lower pressure. There's something like two levels of PEEP. Patient can take breath in both the levels, both in the higher pressure as well as in your lower pressure. This time is being set by us, and this amount of pressure is maintained for this amount of time. And the important thing and the advantage of this mode is that patient can have spontaneous breathing throughout the cycle. Whenever he wants, he can take a spontaneous breath. So the advantage is that bleeding is better, the amount of ventilator-induced lung injury is less, diaphragmatic paralysis is less. So the amount of ventilator-free days is going to be high, and the advantages are definitely there. Other than this mode, there is no difference in any of the modes. The next thing that we always set in a ventilator is we set a tidal volume and we pressures. So what tidal volume we want to set in ARDS? We all know that polytrauma is a major problem. So what happened is, this is a major practice changing trial which came in 2000 by a ARDS network study. This is, if at all there is one study that you need to know in ARDS, it is going to be this study. This is a very major study which was done in patients with acute lung injury. Ventilation was compared with smaller tidal volumes and larger tidal volumes. The traditional tidal volumes that were being used in 1990s and 2000, like what we used to use in anesthesia medicines, it's around 10 to 12 ml per kg. This 12 ml per kg was compared with the low tidal volume. Low tidal volume they took as 6 ml per kg. So what they found was there was a significant decrease in mortality among the patients in whom it was ventilated with the lower tidal volume. There was an increased number of ventilator-free days, and there was a decreased extrapulmonary organ failure. So the discharge was better and the survival was better in patients who were ventilated with the lower tidal volume. This was a very significant study, and after this study, it was changed to a lower tidal volume ventilation, even in cases other than ARDS. So now that we know that low tidal volume is good, whether this low tidal volume per se is good or it is presumed to be benefited by reducing the plateau pressure to less than 30. There was a lot of discussion on this after this study, whether low tidal volume per se is good or it is good only because it is reducing the plateau pressure. So they did a further analysis of the findings of this study and found out that in different levels of plateau pressure, like say 20, 25, 30, and 35, even in all the levels of plateau pressure, when you compare the 6 ml per kg and 12 ml per kg, definitely the mortality was less with the 6 ml per kg. So after this further analysis, it was found that the advantage was predominantly because of the low tidal volume, and it is not because of the restriction of your plateau pressure. Though it can be augmented by the further reduction of plateau pressure of less than 30, it individually has a good advantage. So definitely you can say that low tidal volume is beneficial. So low tidal volume is beneficial. So how low is good? From 12 to 6, we definitely saw there was an improvement in mortality. When further studies were done to see whether further reducing the tidal volume would be useful, it was found that on reducing it from 6 to 4, again, mortality was slightly increased. So this is the NIDAR point, and 6 ml per kg was found to be a good tidal volume for us to ventilate in an ARDS patient. So how do we set it? It is not based on the patient's ideal body weight. It is based on predicted body weight. These are the formulas which we use to calculate the predicted body weight of patient getting admitted to ICU with ARDS. After calculating this body weight, we set the tidal volume as 6 ml per kg. After setting it as 6 ml per kg, further volume adjustments depends on your plateau pressure. If plateau pressure is less than 30, and if you have problem with your carbon dioxide or anything, you can go up on your tidal volume up to 8 ml per kg. But if your plateau pressure is less than 30 and carbon dioxide is good, always maintain a tidal volume of 6 ml per kg. Don't go above. So what is the conclusion? Lung protective ventilation is definitely a good thing. Low tidal volume of 6 to 8 ml per kg is only thing that we need to keep. Always try to limit the plateau pressure to less than 30 centimeters of water. More than 30 centimeters of water, definitely you're going to have barotrauma. Adjust respiratory rate to acceptable minute ventilation. If you have problem with your carbon dioxide, always try to increase your minute ventilation by increasing respiratory rate and not by increasing your tidal volume. You increase your tidal volume, never above 8 ml per kg. If carbon dioxide is going up in the ARDS patient, there is a concept called permissive hypercapnia. You can accept a carbon dioxide of almost up to 60 and around 60. You need not be very stringent on this carbon dioxide, and to maintain a lower carbon dioxide, you should not go up on your tidal. These are extrapolated even to a non-ARDS situation nowadays. Even in anesthesia practice, I think tidal volumes have been reduced further. It is also important if you are using a non-invasive ventilation. As we know, non-invasive ventilator, there was a lot of usage of non-invasive ventilator during COVID period and other things. Even when you are using a non-invasive ventilator, always try to keep a watch on your tidal volume. Never allow the tidal volume to go above 8 ml per kg if the patient has ARDS. So next concept. Now that we are clear about tidal volume and plateau pressure, the next thing that we need to know is PEEP. PEEP is one thing which is very, very important. It is nothing but a positive end expiratory pressure. So the pressure that you need to keep at the level of alveolus at the end of expiration. That's it. Positive end expiratory pressure at the end of expiration. This is being done to keep the alveoli open. Because as we know in the pathophysiology, there are a lot of collapsed alveoli or the alveoli that are flooded with fluid. If you can open up those collapsed alveoli, if you can keep the alveoli open, they can participate in oxygenation, and it can be useful for us to improve the hypoxia. So that is why the concept of PEEP came into practice. Every ARDS patient needs to have a PEEP. They need to keep the alveoli open. So the goal is to maximize the alveolar recruitment and prevent cycles of recruitment and de-recruitment. When you don't have a PEEP, what happens is at the end of expiration, your alveoli is going to collapse completely. And during the next breath, you are going to open a completely collapsed alveoli. So every time the cycle of complete collapse and opening up happens, it is going to cause atelectrauma and biotrauma. So in order to avoid that, again, you need to have a PEEP. But PEEP still has a lot of side effects or the negative outcomes impact, which can be because of it increasing the airway pressure. It can increase the dead space. It can decrease the venous return. Your PEEP can increase intrathoracic pressure, and thereby it can decrease your venous return, and it also can cause back. So you need to be careful about applying PEEP as well. So what was the studies done on PEEP? There were a lot of studies done on high and low PEEP. The most important study was the ARDS network study, that they used a lower and higher PEEP strategy. They use a formula for titration of PEEP. In a lower PEEP strategy, they used something approximately like FiO2 into 0.2. If the FiO2 requirement is 70%, they kept a PEEP of 14. If it is 80%, they kept a PEEP of 16, something like that. And with a higher PEEP strategy, what they found out was, compared to higher PEEP, compared to lower PEEP, higher PEEP patient had better oxygenation, but still there was no survival difference and there was no difference in discharge rates. So there was no major improvement with the higher PEEP. You keep an optimal PEEP, it does not need to be a very high PEEP. So how do you decide the optimal PEEP? You need a PEEP, you don't need a very high PEEP, but still you need an optimal PEEP. So how to identify the optimal PEEP? It is very, very difficult to teach you how to identify optimal PEEP. Only by practice, we need to get used to selecting an optimal PEEP. But this is the pressure volume loop, it would have been dealt with in yesterday's classes in detail. As you know, the lung initially it improves to a certain extent. Till that point, your pressure needed to open up the collapsed or atelectatic alveoli is going to be more. So it opens up slowly. It reaches a point where there is an exponential rise in your opening up of alveoli. After this point, the amount of alveoli that are opened up are going to be very, very good or high. And it reaches a certain point after which whatever amount of pressure you are going to give, it is not going to help you in opening up the alveoli. It is only going to cause over distension. So you need to ventilate in between these 2 points, and especially your PEEP has to be above this lower inflection point, because this lower inflection point is the point above which your alveoli starts opening up fast, and the point below which your alveoli starts collapsing. So you don't want the alveoli to start collapsing at the end of expiration. So you keep the PEEP or your positive end expiratory pressure somewhere above this lower inflection point. So the next thing that you will ask me is whether you can identify this lower inflection point. Definitely, it is going to be difficult. There are a lot of studies done which were correlated with the CT scans, and it was found that once the lower inflection point is crossed, the amount of alveoli that are opened up or the amount of lung that is opened up is going to be more. But still, in certain ventilators, they can give a quasi-static loops, but not in all the patients. Only 25 to 50% will have an identifiable inflection point. So this is only a theoretical concept of identifying a lower inflection point and keeping the PEEP above. Even if you keep a PEEP, what is the problems with the ARDS net approach is that again, it is a heterogeneous population. Not all the alveoli are going to be recruitable. In patients with significant recruitable lung volume, or in patients who have lot of collapsed alveoli, which can be opened up with a PEEP, PEEP is going to benefit. Whereas in patients in whom there is only a very less recruitable lung volume or very less alveoli which can be opened up, it is not going to cause improvement. It is going to cause harm by over distension of the alveoli. So this has to be identified, who are recruitable and who are not recruitable. That again needs a lot of practice at the bedside. So what it was found is, in many studies, it was found that in a large randomized controlled trial, there was no statistically significant difference in mortality between a higher PEEP and a lower PEEP. So higher PEEP is definitely not beneficial. If at all you're going to use a PEEP, use an optimal PEEP, which can be identified if you can identify a lower inflection point, or otherwise there came a concept called driving pressure. In around 2015, this study was published in New England Journal of Medicine. And this concept was very impressive. So identifying the driving pressure. So what is driving pressure? Again, to the same pressure time scalar. As we know, this is going to be your peak pressure. This is going to be your plateau pressure, and it comes down to your PEEP. The difference between your plateau pressure and PEEP is going to be your driving pressure. That is the pressure needed to open up the alveoli in every ventilation. So from PEEP, whatever pressure you need to open up the alveoli, that is the difference between your plateau and your PEEP, is going to be your driving pressure. This pressure is very, very important. What they found out is, this was not a prospective study. This was a study done in patients who were enrolled in other ARDS network studies previously. They took almost around 3,500 patients who were enrolled to the ARDS network study, and they retrospectively collected data from those studies, and what they found out was very, very impressive. In patients, these are patients who are found out from those studies. In patients with the same amount of PEEP, the PEEP is going to be the same. If driving pressure is increasing, if the driving pressure needed to open up the alveoli is increasing, it causes increase in mortality. So with the same amount of PEEP, if driving pressure is increasing, it causes more mortality. Again, the same concept with other patients is that once you increase PEEP in the ARDS patient, increasing PEEP if it is not increasing your driving pressure. If you are increasing PEEP from 10 to 12 and your driving pressure remains the same, it means that survival is better. If the driving pressure does not remain the same, if it starts increasing, your driving pressure starts increasing with the increase in PEEP, it means the mortality is more. Whereas increasing PEEP, if it is reducing your delta pressure, it is going to be very, very good. So this is how we identify a good PEEP. Once you increase the PEEP, if your driving pressure comes down, it means it is a recruitable lung. Your ARDS patient has more recruitable portion of lung. So it is going to be benefited with the increase in your PEEP. At the same time, if increasing PEEP is going to increase your driving pressure, means that recruitable lungs are less, and whatever PEEP you are increasing is going to harm the patient. So in the same study, they found out that delta pressure or the driving pressure of around 60 is optimal. So whenever you have a delta pressure of around 60, it means it is optimal. If it is going above 20, it means that patient is worsening. So how we titrate PEEP? This is again the same concept. As you can see here, this is the normal lung with the normal delta pressure. In this patient, once you increase the PEEP, PEEP is increased from this point to this point. Here, delta pressure is coming down. This means that alveolus is getting recruited. This is good. This increase in PEEP is good. Whereas the same patient from this point of PEEP, if it is increased further, this amount of delta pressure goes up. The delta pressure is worsening. With the increase in PEEP, it means it is overinflation. So it is not a good PEEP. So this amount of increase in PEEP is not good. Again, you need to come down to this level of PEEP. So this is how we identify which PEEP is good. So always initiate the PEEP based on your oxygenation. Maybe the formula 0.2 into this thing can be applied. It can be titrated based on compliance. Assess the compliance by looking at the delta pressure for a level of PEEP. Note the effect of delta pressure with change in PEEP. Titrate PEEP to get the lowest delta pressure or the driving pressure. The driving pressure is nothing but the difference between your plateau pressure and PEEP. If this is going to come down, lowest delta pressure with the increase in PEEP, it is good. So the conclusion about PEEP is that there is currently no evidence that a high PEEP strategy is beneficial. Anatomical recruitment with PEEP is very variable. So high PEEP may be justified in only a certain subgroups. There is no easy way or no clinical way to identify a responder. C for improvement in saturation with increasing your PEEP. Monitor delta pressure when you increase your PEEP. If increase in PEEP causes an inadvertent increase in plateau pressure and drop in tidal volume, it indicates overextension. So the next concept is, first we have seen what is the mode you are going to select, how much tidal volume you are going to select, what is the plateau pressure you are going to maintain, and what is the PEEP you are going to maintain. These are the basic ventilatory measures. Even after doing all this basic ventilatory measures, if there is a refractory hypoxemia, rescue measures can be sought. What are the rescue measures? Inverse ratio ventilation, recruitment, early proning, and ECMO. Inverse ratio ventilation, as we all know, we usually ventilate a patient with a higher expiratory time than a lower than an inspiratory time. We usually keep it around 1:2.5 or 1:3 because you need more time for expiration. It is a passive process. You need more time for the alveolus to completely empty. If that is not going to happen, you're going to have more and more autopy. Whereas in patients with ARDS, to improve oxygenation, what was tried was they prolonged inspiratory time. Inspiratory time prolongation allows regions of lungs that require more time to open. It causes opening of those regions, and they were participating in gas exchange. This is the concept of increasing the inspiratory time. Despite improvements in the oxygenation, there was no improvement in clinically meaningful outcomes in ARDS. If at all you are going to use, what we use is we come down to almost 1:1, not go for an inverse ratio. Mostly the side effects because of the inverse ratio ventilation, it increases the intrathoracic pressure, it decreases your venous return, can cause hypotension. So always be careful if you are using inverse ratio ventilation. If at all you want to use, come down to 1:1, not lesser than that. Next concept is your recruitment maneuver or a open lung ventilation. How do you open the lung? As you saw in the PEEP, PEEP is to keep the lung open, but to open a collapsed lung, you need a maneuver to open it. PEEP is a expiratory maneuver. Recruitment is an inspiratory maneuver. During inspiration, you open a collapsed alveoli. That is called a recruitment maneuver. And during expiration, you avoid the opened alveolus to collapse. That maneuver is called PEEP. So whenever you want to keep a good PEEP, always you need to open up the lung and then provide a good PEEP. And at the same time, whenever you want to recruit a lung or open up a collapsed alveoli, at the end of recruitment maneuver, always you need to keep an optimal PEEP for it to prevent from completely collapsing at the end of recruitment. So recruitment is nothing but aeration of unaerated lung units to take part in gas exchange, opening of collapsed alveoli or driving out edema fluid. Recruitment maneuver, intermittent brief application of your high transpulmonary pressure to open up this. How do we do it? There are a lot of measures in which you can use it. You can provide a CPAP for continuously for 30 to 40 seconds. There is something called 30-30, 40-40. We keep 30 centimeters of water for 30 seconds or 40 centimeters of water for 40 seconds. In other method, what we do is we slowly increase the PEEP and plateau pressure or the PEEP and pressure support. We increase almost up to 60 centimeters of water. Every 2 to 3 minutes, we slowly go up on it to reach a high total pressures to open the collapsed lung. Then we slowly come down on them. When we come down on them, what we do is we identify appropriate PEEP and keep the appropriate PEEP to prevent it from collapsing. So a lot of studies were done in recruitment as well, but oxygenation, it improved slightly, but there was no consistent effect on it. Response is again affected by the etiology of the ARDS, compliance of by tidal volume, duration of ARDS and type of maneuver. It seems equivalent to PEEP alone. It doesn't have any extra advantage over PEEP. So recruitment maneuvers, the final bell was rung in 2017 when a study was done between a recruitment maneuver and the PEEP alone, which found out that patients in whom recruitment maneuver was done, mortality was high. So after this study, recruitment maneuver is not advisable. So the conclusion is that evidence are heading towards harm, probably not better than PEEP. Inadequate evidence of efficacy of the open lung concept. Transient increase in oxygenation can be used as a salvage measure during severe hypoxic episodes, but you need to have a close watch on BP and other complications. So the next rescue measure that we are going to see about is the prone position in the ARDS. This is the most impressive and the most beneficial maneuver that we have found in the ARDS, which can be done in any setup at any point of time. As you know, even in COVID pandemic, a lot of patients were going for awake proning. It gave a good result. Even before the COVID pandemic, we were doing this prone positioning for years together in patients who are affected with ARDS, and we had very good personal as well as evidence-based outcome measures. What happens in prone position advantage is that, as you can see in the supine portion, your heart is going to be anterior. It is going to cause compression of your dorsal portion of your lung. The liver and the abdominal compartment is going to push the diaphragm up, and again, it's going to cause compression on your dorsal lung. And as we all know, the anterior portion of the rib cage or your chest wall is more compliant when compared to posterior portion. So the posterior portion again is going to get affected. When you put them on prone, heart comes front, the weight on the lung is reduced, the liver and the other abdominal organs go down, the pressure on the diaphragm comes down, and the posterior portion of the chest wall becomes more compliant. So because of all these things, there is an improvement in your oxygenation. This can be also translated to improvement both in the transpulmonary pressure as well as improvement in your blood supply and compared to anterior to posterior. So the ventilation perfusion mismatch that was there in the supine position comes down in the prone position. Whenever the ventilation perfusion mismatch comes down, your oxygenation improves. The shunt improves and the oxygenation improves. That is how the prone position helps. So what the evidence that we have, this is a very good study done in 2000, published in 2013 by Guerin et al. This showed that prone position had a very significant improvement in mortality. But the important thing is it was done in severe ARDS patient. Early application of prone positioning was done and prolonged prone positioning sessions were done. That is, prone positioning was done at least for 12 to 14 hours every day. So we suggest if you are going to use prone positioning, do it early in the stages of ARDS. What we do is we prone them at least for the whole day and we keep them supine for around 2 to 3 hours for the basic care of the patient every day. Apart from those 2-3 hours, we almost prone them for 20 to 22 hours every day in severe patients. So in these severe ARDS, early and prone positioning is definitely improved. It has to be considered in refractory hypoxia. In severe ARDS, manpower is definitely necessary. Do it in early stages of ARDS, prolonged duration every day, turn supine every day to look for complications. Always watch for complications close. The next rescue measure is ECMO. ECMO, as we all know, has become a fashion statement after COVID and after.
Excuse me, sir. Excuse me, sir.
Yes, yes.
Sir, that was actually okay. A very great presentation, sir. Can we take ECMO for tomorrow's session, sir? There is a VV ECMO, sir.
Okay, okay. No.
So want of time, sir. Just for want of time, sir.
No
that's why, sir. Please do not mistake us, sir.
No problem. No problem.
Yeah. Yes, sir. Sir, actually, we can go ahead with questions, sir. Sir, after ECMO, is there any other thing? Take home message
I just ended up with the slide.
Yes, sir. Yes, sir. Please, sir. Yes, sir.
ECMO didn't have much of evidence. Initially, it was having. After that, the evidence were coming down. So benefits are not very clear. There were usage of neuromuscular blockers and other HFOV and HF jet ventilation. All those things were found to be not useful. So putting it all together, whenever you are ventilating a patient with the ARDS, always try to treat the cause. Other supportive routine ICU managements are very, very important. Mode, there is no difference in modes. If you have a APRD, you can use it. Calculate patient's predicted body weight. Based on that, set up a tidal volume of 6 ml per kg. Set the initial rate to maintain a good medic ventilation and carbon dioxide. Accept a permissive hypercapnia. And the most important thing is maintain a plateau pressure of less than 30. Set FaO2 and PEEP to obtain a saturation goal of around more than 88%. Increase PEEP with an eye on the plateau and driving pressures. Rescue measures, you can try all these things, but the most important rescue measures that you can do is definitely proning and ECMO. Other than that, there is no major things. These are some of the studies, landmark studies in ARDS based on which I put my study. Thank you.
So thanks a lot for the wonderful presentation, sir. Actually, I will bet that whoever missed today's session on ARDS will definitely regret for this. So there are a few questions from the delegates, sir. The first question from Dr. Muthukumar: is there any studies showing pressure control -VG mode in ARDS? What is your experience?
As I told you earlier, there's no major difference in any of the modes. The only study which has shown some amount of advantage with the mode is with the APRV mode. There is no, I haven't heard about this mode. I don't think there is any major studies on it.
Yes, sir. The next question from Dr. Pankaj. Even now, studies do say that use of low tidal volume of as low as 4 ml per kg also beneficial. Your comment on this, sir?
Yeah, you can go up to 4 ml per kg, but there is no major studies on that. If you go down further, you are going to have other problems like your carbon dioxide maintenance and ventilation maintenance. It is not very important. If you can achieve everything with the 6 ml per kg, it is good. From the ARDS net study, definitely going below the 6 ml per kg is not going to be beneficial.
Yes, sir.
If you want to control your plateau pressure, if your plateau pressure is more than 30 with a 6 ml per kg of tidal volume, and if you have a good carbon dioxide, you can try coming down on your tidal volume. But if your plateau pressure is good, there is no advantage of coming down below 6 ml per kg.
Yes, sir. And final question. What is RI ratio? How accurate is it?
R.
I'm not sure, sir. The question is from Dr. Muthukumar. Even I'm not sure what. Can we mute Dr. Unmute Dr. Muthukumar? Dr. Muthukumar, unmute பண்ணுங்களேன். 1 minute, sir. அவங்க RI ratio ன்னு போட்டிருக்காங்க. What is R bar I ratio? Unmute பண்ணிட்டீங்களா? Muthukumar, Dr. Muthukumar.
Yes, sir. Yes. Sir, there is a recruitment inflation ratio. How is it any way helpful in finding out the recruitability of the lung?
No, whatever evidence is there now, even whatever type of recruitment you are going to do, there is no use in recruitment. Recruitment is only an inspiratory strategy. It will only open up lung. It is only a rescue measure when there is severe hypoxia. It is not going to help you in improving your oxygenation for quite some time, or it is not going to improve other things. Recruitment is not a good maneuver, and it is not advised. I am not very sure about this RI index, but
That's a recruitability index.
Yeah,
Was little loud. I don't know.
these are all some of the parameters which has been brought by the ventilator companies when they try to sell their ventilators. They keep a lot of indexes like this, but there is no major studies on it, and there is no definite advantage of recruiting a patient.
And that PCVG is a pressure controlled volume guaranteed mode. So how is it useful in ARDS?
Yeah, they are all dual modes where you can control two types of parameters. But again, they are all not available in all the ventilators, and even dual modes have been studied in a lot of ARDS studies, and they haven't found any major advantage of using them. When you can monitor the pressures if you are in a volume control mode, or when you can monitor your volume when you are in a pressure control mode, it is more than enough.
Thank you.
So we don't have any more questions. So just a final request, sir. Just if you want to advise two most important points on this talk, how to manage ARDS, what will be the two advice you would give to all the delegates, sir?
Yeah, the two most important things that we need to do is maintain a low tidal volume, maintain a tidal volume of 6 ml per kg throughout the ventilation of ARDS, not on the first day of ventilating the patient. Every day you just check on the tidal volume, see to that it is not going up, because once you put them on a pressure control ventilation, patient's lung starts improving. Once their lung starts improving, their compliance becomes better, and with the same amount of tidal volume pressure, the tidal volume starts increasing. First day with the same pressure, you will have a tidal volume of 300. Next day it can become 350, and the next day it can become 400. It has to be closely monitored, and you need to come down on the pressures to maintain a low tidal volume. If you don't do that, your lung injury is going to be more. So always keep a close watch on the low tidal volume, and keep the plateau pressures less than 30 throughout your ventilation. Even when the patient is on non-invasive ventilation, when they are having ARDS, always try to control your tidal volume. That is the most important thing that we would like to tell you. And the rescue measure, prone ventilation, is very, very useful. Try to use prone ventilation in an early stage.
Yes, sir. Thanks a lot for your time and sharing the knowledge, sir. Thanks once again. Probably we will meet you again for workshop on Sunday, sir. We are eagerly waiting to welcome you. Welcome back. Yes, sir. Thank you, sir. Thank you, sir. And moving on to next presentation. This is on COPD ventilation by Dr. Pradeep Venkappa, sir. A short few words about him. He did his DNB internal medicine from St. John's Medical College Hospital, and then he completed FJ FICM in Australia and EDIC FCICM, and he also holds MBA degree FICCM, PG DMLE, and PG Dip in ECHO. His position, he held as various prestigious positions in the past, and he is now working as consultant intensive care physician at Manipal Hospital, Yeshwanthpur, Bangalore. Actually, today Pradeep Venkappa sir is held up with some other few important meetings. So he will be available for Q&A session after this. He has sent us a recorded video of this session, which will run for around 35 minutes. So this is a recorded video which will be streaming now. At the end of the session, sir would come live to answer the queries from the delegates. So we are streaming the live video now. Sorry, video now, recorded video now.
So hello friends. So thanks Nishant for having me for this talk for Salem Group. So the topic I was asked to talk was on COPD ventilation. How do we do ventilation in COPD in patients who are on NIV and in patients who are intubated and mechanically ventilated? So the first half of my talk, I'll be talking on NIV and its role in COPD. And after that, I'll be talking a bit on invasive ventilation. So we'll see maybe over next 20 to 30 minutes, I should be able to cover this. The whole science of NIV, if you look at, it came way back, maybe around 100 years back in 1936. So this was the first study that came out in Lancet talking about the role of NIV. And as you see, these were the early sort of equipment that was used to deliver NIV. So what do we understand by NIV? Basically, it's a delivery of the same mechanical ventilation principles without putting in the ET tube through the throat. So that's all it means. So it is, but all the other parameters that we tend to use pretty much would subscribe to the science of parameters we set in the invasive ventilation. There are few little differences with that. So, but without endotracheal tube, the ventilatory support that we provide is called as non-invasive ventilation. So before we dwell into how we use the NIV, it is very imperative that every trainee listening to this understand. So what are the effects of NIV in a patient? So this is very, very important. So just put it in a pictorial way. So when we provide NIV, it has a multimodal effect on a patient. So the most important thing is it improves alveolar ventilation and it helps in the recruitment of alveoli in the alveoli which may have been collapsed or which may have been pathological due to pneumonia or fungal so on and so forth. And it reduces the work of breathing. So in COPD, I'm sure everyone would agree that there'll be increased work of breathing. NIV helps in reducing the work of breathing, and COPD, they have exacerbation due to pneumonia where recruitment of alveoli becomes important. It improves alveolar ventilation. Most importantly, many a times COPDs will have concomitant cardiac issues and they may have LV dysfunction, or many of them would have pulmonary with RV dysfunction. It does significantly help in reducing the LV afterload. So we all clearly understand that ventilation and any sort of ventilation has a favorable effect on reducing the load on the LV. So it does reduce the LV afterload. And it helps in stabilization of the muscles also in someone who has reduced minute ventilation. So many of the COPD patients would have muscle atrophy, which may lead to chest wall muscle weakness or any other reason. If COPD has any other concomitant neuromuscular issues where muscle ventilation is reduced or minute ventilation is reduced, it helps in improving that as well and stabilizes the chest wall as well. When we talk about physiology of NIV, there are certain pressures that every trainee needs to understand. So the whole effort that respiratory muscle system puts in place is called TMUS. That's the pressure that is needed for optimal functioning of the whole respiratory apparatus. And this TMUS is dependent on fluid pressure. So there is this elastic pressure. So, and there is resistive pressure. There is this baseline pressure within the alveoli, which is called threshold pressure. So for a good ventilation to happen, so these pressures have to overcome. So any ventilation, one has to overcome the elastic pressures that is present in the lung due to elastic recoil, and there is a resistive pressure, and there is this baseline pressure, which is called threshold pressure. These pressures have to be overcome for effective ventilation to happen. And that's why we call the whole effectiveness or optimal functioning of the respiratory system is this combination of these pressures minus airway opening pressure. So these pressures have to be overcome to open the alveoli and for effective ventilation to happen. So simply put, so the total pressure of the respiratory apparatus with the airway opening pressure is dependent on elastance or the elastic recoil properties of the lung. It is dependent on the volume of the lung, so the amount of tidal volume that is present in the lung. It is dependent on the resistance. It is dependent on the inspiratory flow and the baseline pressure, which is the intrinsic peak that is present. So these are the key elements which determine the optimal ventilation of the lung in a patient. So these pressures have to be overcome effectively for effective ventilation to happen. So any pressure settings that we do, we should factor in the elastance that is present, and any sort of pressures that we send should factor in the amount of tidal volume that is delivered, So any of the settings that we put in should overcome the resistance in the lungs. And these pressures are determined on the inspiratory flow of the gases and the intrinsic heat that may be prevailing. So this is a very important equation. Physiologically, we should be cognizant of these pressures, which have to be overcome for effective ventilation to happen. When we talk about non-invasive ventilation, there are a lot of terminologies we use. We use CPAP, we use pressure support, we use BiPAP, and we use NIPT. So they are all interchangeably used, but the physiological concept, because these nomenclatures tend to change with the type of instruments that we use, but fundamentally, the core essence of the science that remains is that those pressures that need to be tackled for effective ventilation to happen. We'll just try to delineate as to how we understand this. So as I said, any NIV reduces afterload. So there is effective recruitment of the alveoli that happens. So we understand with NIV, there is a good recruitment of alveoli, and this recruitment of the alveoli helps in reducing the elastic pressure. So it overcomes the elastic pressure. When the intrinsic P or the PEEP you provide in the ventilation helps to overcome the threshold pressure, which I mentioned. And all in all, these, by overcoming these pressures, it helps to reduce the shunt fraction. So shunt is where your alveoli is not participating in the gas exchange. So it reduces the shunt fraction by recruitment, and by providing PEEP, it overcomes the elastic pressure and the threshold pressure and helps in effectively circumventing the shunt issues. So this is how the NIV helps in optimizing the ventilation. So what do you understand? So this is with regards to the pressure support or only the CPAP that you give. But in NIV, in COPD, we add inspiratory positive airway pressure along with the CPAP or the pressure support ventilation. So we add IPAP. The inspiratory pressure, what we add, what does it do? It increases the tidal volume. And this increase in the tidal volume in the alveoli is needed to reduce your CO2. So we all understand, all the listeners here would understand that in COPD, our whole effort is to remove this carbon dioxide because there is difficulty in getting this carbon dioxide out in COPD. That's why they have CO2 retention. By providing inspiratory positive airway pressure, there is increase in alveolar tidal volume, which helps in reducing the CO2. That's why we add IPAP. That's why it's called bi-level positive airway pressure. And this is also shown to improve the surfactant production by the alveolar pneumocytes. And by giving IPAP, it will reduce this elastic pressure and resistive pressure comes down. Because we saw in the previous slide, the pressure support or the CPAP that you give tends to overcome the resistive pressure and the threshold pressure. By adding IPAP, it reduces the elastic pressure and the resistive pressure and increases the alveolar tidal volume and reduces the carbon dioxide. All in all, it reduces your whole respiratory effort or the respiratory apparatus pressure. It reduces and reduces the work of breathing. So this in principle is how this NIV is beneficial in COPD. So when we say BiPAP is we add inspiratory positive airway pressure plus expiratory positive airway pressure, which you can also call CPAP. You can also call it as pressure support plus EPAP or plus CPAP. So we add inspiratory positive airway pressure in addition to CPAP or expiratory positive airway pressure. That's why we call as bi-level positive airway pressure. So what is the physiological rationale or benefit of using NIV in respiratory failure? As I said, in addition to all those pressures that it overcomes the elastic pressure, it overcomes the resistive pressure, it overcomes the threshold pressure, and it offers PEEP, it reduces the shunt fraction. So by doing all this, it significantly reduces the shunt fraction. As you see, shunt fraction is this part of the alveoli is not participating in the gas exchange. So by providing NIV, it tends to circumvent this alveoli which is not participating by recruiting the alveoli, and it improves the oxygenation. And NIV also helps to improve ventilation perfusion mismatch. Here, the alveoli are getting ventilated, but there is a compromise in the perfusion because of compression of the vessels due to emphysematous chest. So there is physiological dead space that increases. So this also tends to be optimized with NIV. And diffusion impairment is another cause of respiratory failure where effective exchange of gases are not happening. And there are other issues where you may have thromboembolism in the pulmonary circulation, which also leads to ventilation perfusion mismatch. So just to show you pictorially, before NIV, you would see the alveoli would be collapsed. So post NIV, you will have these alveoli which are well recruited, well optimized, and you see good ventilation perfusion matching happens. So there is improvement in the ventilation perfusion sort of a ratio that happens, and all in all, it improves the oxygenation. And it is also important to understand that NIV is helpful in hypoventilation disorders. And it is also, as I said, it augments the functioning of your respiratory muscles in situations where your minute ventilation is down due to neuromuscular weakness. And many of the end-stage COPDs would have sort of a muscle atrophy and chest muscle wasting. And there also it helps to improve minute ventilation. With NIV, it tends to improve the minute ventilation by accentuating the functioning of the respiratory muscles. So that is in sort of a quick sort of a overview on physiological rationale as to how NIV helps and what are the pressures that it overcomes to improve oxygenation is what we saw. So the indications for BiPAP is predominantly in asthma, COPD, and sometimes even in acute respiratory failure. So there are certain contraindications for NIV. I'll just put a cartoon. So any patients who has inability to clear the secretions, who has a poor sort of a cough reflex or who has upper airway obstruction. So these are the situations where NIV cannot be used because they should have good airway reflexes. They should be able to protect the airway. Or severe acute asthma where there is severe bronchospasm, NIV is not something that will be useful, and in pneumothorax it can worsen. So these are about the where the GCS conscious level is very low. These are related sort of a contraindication because they won't be able to protect the airway. Or in someone who is very hemodynamically unstable, NIV can sort of offset the stability. So these are some of the accepted sort of contraindications for NIV. One of the complications of non-invasive ventilation in COPD. So if someone has a COPD with a head injury, it can worsen the intracranial pressure, or someone COPD with a stroke or any neurological conditions, it can increase the ICP. And someone with glaucoma, one has to be cautious, it can increase the intraocular pressure. And one knows that when someone is on NIV, there will be a lot of nasal congestion, dryness of the mouth. So there will be discomfort or intolerance due to claustrophobia, and where there is sometimes there can be a risk of aspiration. Because it's a positive pressure ventilation, if someone is low on the volume status, it can cause hemodynamic instability with hypotension. So there can be gastric distension. So these are some of the complications one need to keep in mind when you're using NIV in a COPD patient or for any patient for that matter. So just move to what are the equipments that are needed when you're using NIV. So one thing is in ICU, when we use NIV, it is the ICU ventilators. We do not use home CPAP or home BiPAP for patients in ICU because in ICU, it is imperative that we understand that these patients are sicker. They may have a concomitant pathology. It could be pneumonia, it could be pulmonary edema. So it is expected that we use a proper ICU ventilator with a walled oxygen. So one of the prerequisites is they should have a walled oxygen to deliver high flow or gas flows. And mask fit is something that is very important. So whenever you are using NIV mask, it is important to make sure there is no leakage of the mask that you have put in. And generally, NIV, you can have a single limb or a two limb. Like when I say it is the ICU sort of a ventilator we use, it is expected that we have a two-limbed circuit. If for some reason you are using a one-limbed circuit, one has to put in a PEEP valve because with the resistor or the flow or threshold resistor. And this PEEP valve helps you to provide adequate PEEP in patients. But if it is a two-limbed circuit, then you would obviously set the PEEP on the ventilator that patient is connected to. And it is desirable that the length of the tubes that are used in COPD are shorter length to reduce the sort of the resistance when you are ventilating. And it is desirable the diameter of the tubes is wider. and there should be adjustment for variable FiO2. So all these are taken as something that will be present when you're using a standard ICU ventilator to provide NIV, because you will have a PEEP adjustment on the machine and you would have ability to tweak the FiO2 on the machine, but keep an eye on the length and the diameter of the tube. But these are all of standard length, but ensure that they're not very long. Shorter the tubes, better it is. And the NIV machine is meant to have flow and pressure sensors to identify and to sort of follow up on these pressure and flows that are set for these patients. So the sensors, because many times you would see the sensors may be dysfunctional, then you would know what are the target flows and pressures that you need to set on the machine. Another important thing, as I said, when someone is put on an NIV, there is a lot of dryness of the mouth, and this can lead to sequestration of all secretions. So good humidification is also something that is needed, and it is very often you see that humidification is sort of underwhelmed or not given importance. So it is important that when the NIV is being provided, you need to have a good humidification process when this is provided. And any NIV circuit should have ability to connect the nebulizer. So you have the jet nebulizers which should be connected. So the tools that you are using for providing NIV should have ability to connect this jet nebulizer or vibrating mesh nebulizer alone, as because in our ICU we use vibrating mesh nebulizer. So we should have ability to connect to these vibrating mesh nebulizers to provide nebulization, because COPD patients would need ongoing nebulization. And this machine should have backup battery and backup apnea sort of tools. So when we are dealing with a patient with COPD and exacerbation, so these patients, our aim is to obviously improve the pH, because these patients will have acidemia due to high CO2, and our aim is to reduce the CO2 in these patients, and our aim is to reduce the shortness of breath or the work of breathing. And all these targets have to be carefully monitored every hour, and a call has to be taken whether NIV is helping the patient and alleviating their symptoms. And it's shown that early usage of NIV in COPD reduces the length of stay, and it does reduce the mortality and does reduce the intubation rates if used early and effectively. And the success rate of NIV in COPD is very good. It's put at 80 to 85%. So what is most important is the use of NIV in COPD. This is very important, is a quality indicator. And every patient who comes to ICU with COPD exacerbation should be given a trial of extubation. As you see, 95% of the COPD exacerbation should get NIV trial, which is a quality indicator. If you are not providing NIV and jumping to intubate without a trial of NIV, is a breach in the quality indicator. This is just an audit that we did in our hospital to see how effectively we are using it. NIV, and this was the percentage of the cases that we were using NIV. 40% of the respiratory cases we had used NIV, and around close to 30% we used in cardiology patients, so on and so forth. So what are the ventilatory settings that is expected in COPD? So the mode we put on is spontaneous or timed mode. The IPAP we generally put at 12 to 15 centimeters of water, and EPAP of 4 to 5 centimeters. So we keep a differential of around 7 to 8 in IPAP and EPAP when we are setting these pressures between IPAP and EPAP. So the trigger we put at a maximum sensitivity in patients who is very tachypnic, who is very conscious. We put the trigger at a high sensitivity. If someone who is obtunded, who is not taking enough breath, we put the sensitivity much lower, because you need it to be triggered for any breath that they initiate. And the backup rate we put up around 15 breaths per minute. So these are the initial setting, and backup inspiratory expiratory ratio we put at 1:3. So these are some of the basic sort of settings that we put on the ventilator. So when we are setting it up, so make sure that there is no contraindication when you are connecting the patient to NIV. And before NIV, patient should be on non-rebreather mask so that they are adequately oxygenated. And most importantly, patients have to be explained about the NIV as to what we are doing with the patient, and they have, because they'll be very agitated and they'll be very apprehensive. They wouldn't understand because suddenly you are connecting a mask where they cannot speak and they would be very apprehensive. And so the compliance of the patient to the machine becomes very important. So constant reassurance to the patient is pivotal in the success of NIV. And as I already mentioned, the correct mask fit is something that is very important to ensure effective ventilation when you are giving NIV, to ensure there is not much leakage of the gases that are happening. Most importantly, as I said, when someone is connected to NIV, it is important to see whether patient is responding to the NIV, whether the parameters are getting better. It is important once you put them on NIV, they need to be more diligently and vigilantly watched, monitored, observed, and regular assessment has to be done. There are various other masks like nasal masks, there are full masks, and there is helmet mask. I am sure many of the listeners would have used many of these. In COVID, especially this helmet mask became a little more popular. So how do we monitor the response? Once we connect the patient to NIV, one has to see if the tachycardia with the patient would be due to exacerbation of COPD is settling down with reduction in the heart rate, and whether the oxygenation is improving, and he or she would be very hypertensive when there is exacerbation, so the blood pressure is settling down and the tachypnea is settling down. So these are some of the favorable parameters which would give you comfort that patient is responding to the NIV that you have given, and look for the accessory muscles of breathing, whether these accessory muscles of breathing are settled down. And the patient will have been very drowsy because of high CO2. Look for improvement in the mental status and look for the coordinated muscle movements. Look whether the patient is getting more comfortable, whether the diaphoresis is settling down, whether shortness of breath is settled down. And very important to keep monitoring arterial blood gas at least every 4 to 6 hourly to see if the pH is getting better, if carbon dioxide is coming down, oxygen is improving, so on and so forth. So these are the quintessence of NIV is to see whether the parameters trends are getting more favorable after the initiation of NIV, and that is correlating to the clinical improvement of the patient. So treatment failure is you have connected the ventilator, you have put the settings, IPAP, EPAP, you have made sure you are giving good humidification and you are monitoring. But if patient is getting more obtended and is getting more acidemic, and CO2 is rising despite whatever good parameters you have put in, and there is worsening or non-improving ABG, or when there is intolerance or failure to coordinate because patient may be very restless and not complying in keeping the mask and not sitting with sedation. So these are failure where you have to call it as a failure of NIV and move on to intubation and mechanical ventilation. So intolerance is one of the key things that many times would be a reason why sometimes NIV fails and one has to get intubated, or there is no improvement in the oxygenation, or is getting more and more hemodynamically unstable, or when there are cardiac sort of a dysrhythmias that are setting in. So this becomes a very difficult situation to manage with NIV, and many times we may have to move towards intubation. So for the clinical improvement, one has to look for keeping the tachypnea settled, tachycardia settled, and pH is improving, and saturation is more than 90% on FiO2 of 40%, and so on and so forth. At that point of time, you can think of weaning the NIV. Just to look at the evidence, so there are multiple robust studies which have shown that NIV is significantly beneficial for pulmonary edema. There are around 23 randomized controlled trials and 3 meta-analyses which show that NIV really helps. In COPD, which is of interest in today's discussion, there are 14 randomized controlled trials which have shown significant benefit with the usage of NIV. And there are 8 randomized controlled trials in hypoxemic respiratory failure. In immunocompromised, there are 3 randomized controlled trials and multiple observational studies. So for COPD, the use of NIV is being given grade 1A recommendation. Pulmonary edema, it is given grade 1A, so which is a strong recommendation with good scientific evidence substantiating the usage of NIV. For hypoxemic respiratory failure, it is grade 2B recommendation. So very briefly, I'll look into just very briefly on 1 or 2 studies. In COPD, these are the studies which have shown BiPAP is better than CPAP or pressure support with regards to outcomes, and BiPAP is shown to be superior in improving gas exchange and in reducing the work of breathing in patients with COPD. So, and these are the studies which are shown that in COPD, the use of non-invasive ventilation significantly reduces the mortality, significantly reduces the risk of infections, secondary infections, and significantly reduces the risk of intubation rates by 20% with the usage of NIV in COPD as compared to mechanical ventilation. And this is a big meta-analysis which came some time ago in UK, which is a meta-analysis of 14 randomized controlled trials, where they compared NIV with compared to the other group. It did not get NIV, and they showed the mortality was significantly less, treatment failure was significantly less, intubation rate was significantly less, and hospital length of stay also was shorter. So because of all these robust studies, around 14 randomized controlled trials that are shown very conclusively that COPD, the trial of NIV has to be given. It is included as quality benchmark, and it is a quality indicator for every intensivist that a trial of NIV has to be given before you resort to intubating and mechanically ventilating. And this is the most recent sort of a review article that came, non-invasive support for adults with acute respiratory failure, which came on NEJM in 2022, where if you see, before invasive mechanical ventilation for COPD, a trial of NIV has to be given. And even to that effect, there is a strong recommendation that even after extubating the patient of COPD, one can give a trial of non-invasive ventilation, extubating to NIV to prevent reintubation in patient at risk for extubation failure, as shown is something that is very important that came out of this article. So all in all, NIV is the way to go. Even before intubation, give a trial. Post extubation, to prevent failure of extubation, they can be bridged with NIV support and then weaned off later is the way to go. So the summary is NIV is proven to have sound physiological rationale. When I say sound physiological rationale, it is those multimodal effects. It recruits the alveoli, it overcomes the resistive pressure, it overcomes the elastic pressure, it overcomes the threshold pressure, and it reduces the respiratory effort significantly. And it reduces the shunt fraction, improves the ventilation perfusion mass match. So all these are the sound physiological rationale as to why NIV is significantly beneficial. It is shown a proven safety in saving lives in last 1 century, and it has shown to influence favorable outcome in these conditions: pulmonary edema, COPD, hypoxemic respiratory failure. And there are more than 55 good quality practice-changing trials to substantiate usage of NIV. And we have seen NIV was a life savior in COVID-19 pandemic. So that's about the role of NIV from the practical standpoint for all the clinicians who may be hearing to this as to its role in COPD. Now we'll go to patients who are intubated. So where NIV has failed, then COPD patients get intubated and mechanically ventilated. So what is the role of? So basically when someone is intubated and mechanically ventilated, what does the ventilator do? It pushes the oxygen in and gets the carbon dioxide out. You have clearly understood in COPD, the basic problem the patient has is in the ability to get this carbon dioxide out. You need to understand this very important equation in any patient who is on a ventilator. So the airway pressure is dependent on flow of gases through the airways and the resistance the airways have, and it is dependent on the volume divided by compliance, which determines your alveolar function with the P, because every alveoli is open because of the baseline pressure, which we call as P. So your whole airway pressure is equal to flow into resistance plus volume divided by compliance plus P. And this equation is something which should be drilled into everyone's mind, is what determines the whole science of mechanical ventilation, because your whole gas flows within the lungs and that come out of the lungs are determined by these sort of a parameters or variables. So airway pressure is dependent on the flow, and this flow is something that we can set on a ventilator. And resistance is something that is very intrinsic to the lung, and resistance is something we cannot set. And resistance is determined by the pathology, because we know in COPD resistance increases, and this is something which is determined by how your lungs are. And the volume is something that we can set on the ventilator, and the peak is something that we can set on ventilator. So there are two things we cannot set. Resistance is the intrinsic nature of the lung, and the compliance also is the intrinsic. Because if you have a pneumonia, your compliance would have come down. In COPD, compliance is usually normal or high if there is no pathology. In COPD, as I said, the whole problem is for the carbon dioxide to come out, and there is difficulty in for the carbon dioxide to come out, and many a times there is reduced time that is available for this carbon dioxide to come out in these patients. So what happens, because they are breathing so fast and there is reduced time that is available for this carbon dioxide to come out, there is more of trapping of this carbon dioxide within this alveoli. Because it gets trapped, so the alveoli gets bloated, which we call as dynamic hyperinflation. As the name sounds, the alveoli gets bloated because there is not enough time for this carbon dioxide to come out, and because elastic recoil properties of this airway is lost. Because there is bloating, there is the pressure within this alveoli increases, which we call as intrinsic heat. So the reasons for this is there is increase in the inspiratory time. They take enough breath with good timing, but their expiratory time is low. There is inadequate time that is available for the carbon dioxide to come out. And these patients are tachypneic because they have high respiratory rate. Because your respiratory rate is high, your expiratory time gets shortened. Your absolute expiratory time gets shortened. And the larger tidal volume also accentuates this bloating of this alveoli. So all in all, in these COPD patients, when you connect them to ventilator, they tend to have hemodynamic compromise or blood pressure tends to come down. Why does this happen? Because in patients where already your alveoli are bloating and the pressure in the chest is so high, so your venous return decreases. So when there is a hemodynamic instability, it is desirable that you disconnect the patient from the ventilator and allow the gases to come out, because your whole venous return reduces because of the increase in the intrathoracic pressure, which is causing the hypotension. And if you are facing this situation for a very brief period of time, you can discontinue the patient from the ventilator to reduce this dynamic hyperinflation. Okay. So the problems that in COPD that we face that needs to be circumvented is an increased airway resistance, and we saw that there is reduced time to get this carbon dioxide out, which leads to dynamic hyperinflation. So this is one problem which we need to address in any patient of COPD who is mechanically ventilated, that we need to improve the time. So because there is reduced time for this carbon dioxide to come out, we have to increase the time so that enough time is given for this carbon dioxide to come out. And we have to address this increased airway resistance by bronchodilation. And we have to circumvent this respiratory acidosis. And then the other problem we need to circumvent is to alleviate or mitigate or minimize the risk of them developing pneumothorax because of the increasing in the pressures. So what are the reasonable initial settings that we should think of in COPD? The reasonable initial setting is assist control mode ventilation or control mode ventilation is desirable. Tidal volume has to be lower, because we saw in the previous slides that increase in the tidal volume is something which will worsen your dynamic hyperinflation. And initially you can put them on 100%, and respiratory rate has to be kept at a lower respiratory rate, because many of the clinicians would think if CO2 is building up, you'll just increase the respiratory rate. Increase in the respiratory rate will worsen the dynamic hyper, because we saw when you increase the respiratory rate, there's not enough time that is given for the carbon dioxide to come out, because tachypnea is not good. You have to reduce the respiratory rate. And the key thing is to increase the IV ratio. So expiratory time has to be increased because they have enough time for this carbon dioxide to come out. And peak, you can keep it initially less. I think 5 is reasonable, or you can reduce it further. So there is a concept of the intrinsic, the peak that we need to keep to circumvent the intrinsic peak. So 2/3 of the intrinsic peak, up to 2/3 of the intrinsic peak is sort of allowed, but not more than that, because that can worsen the dynamic hyperinflation. And the inspiratory rise time is around 5. So the rise time is the time that is set for the set goals to be achieved, or for the set pressures or the flows to achieve. So when I said there is increase in the respiratory rate, as you say, when there is a tachypnea, your whole expiratory time gets shortened. But on the same note, if you have a longer expiratory time, you have enough time for this expiration to happen and reach the baseline. So it is very important that we reduce the respiratory, because if you keep the respiratory rate high, your expiratory time also comes down, your carbon dioxide builds up, your intrinsic peak builds up. Okay. So that is something that one needs to pay attention. So what we need to understand is, if you have a longer inspiratory time, it improves oxygenation. It improves oxygenation by improving the mean airway pressure and by redistribution. And longer inspiratory time lowers the peak airway pressure by increasing the time for the tidal volumes to be delivered. So we don't want this. So if you put a longer inspiratory time, basically there is more in the tidal volume which is not needed. So what we need is shorter inspiratory time and longer expiratory time, because the longer expiratory time will allow time for the carbon dioxide to be expelled, and it lowers the risk of dynamic hyperinflation or intrinsic peak. And your longer expiratory time will also mitigate your hemodynamic instability that will happen because of increase in the dynamic hyperinflation that tends to set in. And as I said, most of the trainees would know, when we call air trapping, you have to look at this is the flow time scalas you need to look at. So because there is inadequate time for the expiration to be completed, there is this air trapping which we call as auto peak that tends to set in. So higher tidal volume is bad for COPD. That's why we keep lower tidal volume, and we lower the respiratory rate, and we tend to keep the peak low, and we tend to increase the expiratory time. So higher tidal volume, higher respiratory rate, and shorter expiratory time is what will lead to worsening of intrinsic peak or dynamic hyperinflation. So the treatment is, we need to lower the tidal volume, we need to reduce the respiratory rate, and we need to increase the expiratory time, because the whole problem in COPD is there's not enough time for the carbon dioxide to come out. We need to provide more time for this carbon dioxide to come out to prevent this dynamic hyperinflation. And this is the flow volume group where you see during expiration, it is not touching the baseline, which is the auto peak. So the summary is, for in patients who are mechanically ventilated, remember your whole principle of ventilation is governed by flow of gases, which you can set in a ventilator. Resistance is what is intrinsically determined by the nature of the lung. Volume is something you can decide. As I said, more tidal volume, more dynamic hyperinflation in COPD exacerbation. So that is something you can set. Compliance is determined by the intrinsic nature of the lung, and peak is something that you can set. And the determinants of ventilation, which is to improve oxygenation, reduce the carbon dioxide, and this can be achieved by tweaking your inspiratory time. You want more oxygen, you have to increase inspiratory time. You want to reduce carbon dioxide, you have to reduce inspiratory time and increase the expiratory time. And volumes have to be adjusted accordingly, and peak has to be adjusted accordingly. And always look for intrinsic peak should be less than 10. So look at the flow time pattern and look at the expiration, whether it is touching the baseline. If it is not touching, then there is intrinsic peak, and you have to address it by tweaking all the variables. And this can lead to severe dysynchrony, and that is something that one needs to keep in mind. All in all, if you are not addressing these dynamic hyperinflation and intrinsic peak, it will stress the lung. It will put enormous stress to the lung, and the work of breathing increases, and the respiratory effort also significantly increases. So our whole effort is to reduce the stress on the lung and reduce the respiratory effort by tweaking all these variables. So that is in brief about the practical approach as to how we can optimize ventilation in COPD. So thank you one and all. So you can visit my website www.pradeepnandapara.com to read to this lecture. So this is more of a basic tenets of management I have covered. So a lot of physiological components into it, but what is really elucidated is more from the practical standpoint, which should help clinicians to manage COPDs in a safe way. So thank you, Vandal.
So thanks a lot for that wonderful presentation, sir. Um, Sir, we have two questions, sir. Sir, are you,
So, hey, thanks. So thanks,
Yeah,
Nishant,
thanks,
for
Nishant.
having me
I'm,
for this topic
thanks,
in
Nishant. I'm
for
able to
Salem
hear
Group.
you.
yes, sir, please.
So the topic
I
I
have
think
two
the video has
talk
again
was on
started. We can
COPD
stop the.
ventilation.
I will stop the video.
How do we do ventilation in COPD?
So we have two questions, sir,
Uh,
from Dr. Vijay Ravi.
Yeah.
Which sedation and anxiolytics are safe in apprehensive COPD asthma patients on NIV? On
Yeah,
NIV.
see, I think see, on NIV, we use dexmedetomidine, that is very safe and stable. And if they're very super anxious, hyper anxious, we can use a bit of opioid and we can use haloperidol. But most of the time, dexmedetomidine is a good drug. See, more than the drugs, Nishant, what is most important is to explain to them, alleviate their apprehension, reassure them that the NIV that is being used is to help them breathe better. And many a times that would be more helpful rather than the medication. So most of the time we explain to them, sincerely tell them that whatever we are trying to do is to help them breathe better, and it is only to help them get better. That would be more impactful than medication. But of course, if someone is very restless due to any other reasons, then dexmedetomidine is what we tend to use, because opioids are generally avoided because respiratory drive gets affected further with your opioids. So we wouldn't really encourage, but if someone is so agitated, young patients, so on and so forth, you can use a little bit, but dexmedetomidine is a reasonably safe drug, and some antipsychotics like haloperidol also could be used if there is a ICU delirium as a component involved in restlessness, Nishant.
Okay, sir, fine. So thanks for the answer, sir. Next question, sir. In case of, sorry, 1 minute. Yeah, from Dr. Muthukumar, how short should we decrease the inspiration? Will it not produce dead space ventilation?
No. See, I think that the whole concept of inspiratory time and expiratory, see, your respiratory cycle time is fixed. There, you can only determine what should be your expiratory component and inspiratory component. So, as I said initially, the settings is you can prolong when you prolong your expiratory time, automatically your inspiratory time comes down. We have to clearly understand that inspiratory time is needed to improve the oxygenation, improve the mean alveolar pressure, and improve the oxygenation. You need more inspiratory time. Like sometimes in ARDS, we do inverse ratio ventilation, where we increase the inspiratory time more than expiratory time. But the problem with that is you have a CO2, which is an issue. So if your oxygenation is an issue, then you have to play with inspiratory time. But if your carbon dioxide is an issue, because in COPD, oxygenation is not an issue. It is always the carbon dioxide retention, which is a problem, which is creating hemodynamic instability and which is worsening your whole conundrum of the pathophysiology. So you have to increase the expiratory time so that your ratio, you can start off in 1:3. Sometimes we even go up to 1:4, 1:5. When you do that, obviously your respiratory rate, your minute ventilation will increase, and your respiratory rate has to be shortened to accommodate that prolonged expiratory phase. So dead space ventilation would not get affected. It would be mainly your oxygenation is an issue, then inspiratory time shortening can worsen the oxygenation. So that is the concept that we need to bear in mind.
Yes, sir.
Yeah.
Final question, sir, from Dr. Pankaj. In case of COPD, to decrease carbon dioxide, we have adjusted IE ratio accordingly. Now, how should we change tidal volume, or sorry, after that, what should we change? It is tidal volume or respiratory rate?
Yeah, see, who is this Dr. Pankaj? Very important. Play with all three components, Pankaj. Don't let us not fixate ourselves saying I'll only increase IE ratio and keep tidal volume high, because then you are offsetting the beneficial effects. See, our whole understanding is your increase in tidal volume, increase in inspiratory time, is all to do with increasing oxygen. But if your intent is to reduce carbon dioxide, three components you have to look at, Pankaj. One is obviously expiratory time will be prolonged. You have to prolong the expiratory time, and most importantly, reduce the respiratory rate also, because they both go hand in hand. And we have to lower the tidal volume, keep it at around 6 to 8 ml per kg in that sort of a ballpark to keep the tidal volume low. And all this multimodal approach is the way to go. And if someone is tachypneic, you can use sedatives and other bronchodilators and other pharmacological medications also to reduce that's why in very refractory cases, sometimes we use muscle relaxants to take complete control, especially when they're intubated mechanical ventilators, so that we have a complete control on the respiratory rate, Pankaj. So the answer for you is, it has to be all three components addressed concurrently rather one after another. So that
Yes,
would
sir.
be the way, Shant.
Yes, sir. So I don't find any other questions in the chat box, sir. Thanks a lot for sharing your time in your busy schedule, sir. Thanks once again.
Thank you.
Thanks for
Thank you,
joining us,
Nishant,
sir.
for having me.
Please, sir.
Hope it was useful for all they can rehear to this lecture. I can send you this lecture by WhatsApp.
Yes, sir.
It's on YouTube, so you can, anyone who wishes to rehear can rehear to this. There are few more
Definitely.
lectures connected to this. There is one whole lecture on the gas flow dynamics, because I have not gone into the whole details of the physiology aspect. There is one video only on the gas flows, how they happen in all these pathologies, more of physiological standpoint. If anyone is academically interested, you can go through that, because I put up this lecture more from a practical standpoint, Nishant.
Definitely, sir. I totally agree to that. Thanks a lot for your time once again, sir. Thank you, sir.
Thank you.
Thanks for
Thank you,
joining us,
Nishant.
sir.
Thanks, everyone.
Thank you.
Thanks, everyone.
Thank you, sir. Thank you, sir.
Have a great day. Yeah.
Thank you, sir.
Yeah.
So moving on to the final presentation of the day, I invite Dr. Anup Kumar, sir. So the topic is to be on HFNs in applications. Short word about him. He is currently the Director Critical Care Medicine for Aster North Kerala Cluster. And he is also a teacher and examiner, academically interested. Many of you have known from his webinar, from Telegram channel Webinar Campus. And he is visiting professor, critical care medicine, MRCP teacher. And he is currently working in Aster MIMS Calicut, Kerala. And areas of interest are infectious disease in ICU, clinical nutrition, snake bite management, critical care ultrasound. And to his credit, he has the best doctor award in Kerala government when the Nipah virus got broke up. And then Kerala government advisory panel member on COVID management and managing director of Webinar Campus and editorial board member of Journal of Acute Care. Anup sir, over to you.
Thank you so much for giving me this opportunity, Nishant.
Yes, sir, please, sir. Thank you, sir.
Hope my slide is visible.
Yes, sir. Audio is clear. Slides are visible, sir. You can go ahead, sir. Thank you, sir.
Okay. So it's already late. So we'll be going through the high flow nasal cannula therapy, the basic principles, and where and all we can use this. I'm not going into much studies and evidence, etc. We'll be just touching upon the basic concept about high flow nasal cannula therapy. I think before the COVID-19, this was not a very popular device, and majority of the ICUs were not using this one. But after the COVID, I don't think that I have to talk to you on the basic principles or how to use the high flow nasal cannula and all, because all are very familiar in using this machine. But still, for the completion's sake, I'll just go through the basic concepts. So this is the one which you have to basically understand. So whenever you breathe fast and then the oxygen is supplemented through the nose, so there is a huge amount of air coming through the inspiration. So even if you're giving a low flow oxygen, the peak inspiratory flow rate is almost 25 to 35 liters even at rest. So whatever oxygen you are giving will get diluted with this 35 liters of 21% of oxygen. So that is the usual issue when you give a nasal or like a oxygen through the face mask. So here you can see the oxygen up to 10 liters, the nasal prongs, and up to 5 liters, etc. So during the peak inspiratory flow, whatever oxygen you are giving will get diluted with the 21% of the air, and definitely these will dilute that, whereas the high flow nasal oxygen will wash out this peak inspiratory flow by the atmospheric air. The current practice of oxygen therapy, as you all know, we will be either using a nasal cannula, which will be non-humidified oxygen, and again it is a variable FiO2. And as you are well aware, nowadays we are not putting the sterile water or the distilled water into the humidifier, because there are many guidelines. Even the BTS guidelines strongly recommends against using the water in the humidifier, because that will again increase the chances of infection. And the humidification obtained through this bubbling is very, very negligible as well. Then we have the mask, where you can go up to 5 liters, and the FiO2 will be 28 to 50%. And one thing you have to always remember is you will have to use minimum 5 liters just to fill the dead space. Otherwise, the chances of carbon dioxide rebreathing will be more. So the whatever oxygen is coming through this the tube, that will be pushing out the exhaled carbon dioxide through the vent. So if there is no adequate flow through the oxygen tubings, definitely there can be carbon dioxide rebreathing. That is why whenever we put a normal mask, we give almost 5 liters per oxygen. But what are the challenges when we use these nasal cannula and oxygen mask? So first thing, maybe the patient won't keep the mask on every time. A limited flow range with nasal cannula, like you can go from 1 to 3 liters. Whenever we go more than 3 liters, the dryness, the discomfort, etc. will be high. Patient want to eat, drink, sleep, talk, etc., which may not be possible with the face mask. And the broad and complicated range of mask and cannulas, the frequent interruptions to therapy, because during eating or talking, etc., we'll have to remove the mask. Then the liability, the inability to accurately deliver oxygen. I've explained why it cannot deliver the proper oxygen. So the low flow devices has a variable flow, where you can see that the oxygen which is given at 6 liters, when you're giving a 6 liters, it is a room air flow which is giving almost 15 to 29 liters, because the peak inspiratory flow is 25 to 35, which I've already explained in the slide. So whatever oxygen is giving, so that will get diluted with the room air, and in effect, you may not be able to deliver the amount of oxygen what you are giving. That is why even when you are giving 100% oxygen of 6 liters, you may not be able to achieve an FiO2 which is more than 35 to 40, because that is getting diluted with another 30 liters of room air. So what are the basic goals of this HFNC, especially in optimizing the spontaneous breathing? These are the three the main components HFNC can offer. One thing is respiratory support. Second thing is proper airway humidification. And third one is the patient comfort, the patient can eat, talk, etc. Regarding the respiratory support, it can give supplemental oxygen, as you all know. It can have a dynamic positive airway pressure, or it can have a PEEP effect, which we'll explain later how to attain a PEEP effect. And obviously, it is having a reduction of dead space as well, which we have already told. Like whenever the low flow oxygen is there, the dead space will be there. But when you are giving a high flow oxygen, all the dead space will be washed off by the oxygen or the air what we are giving. So it usually optimally humidify the total flow, because we have a inbuilt humidification system. The flow range can be up to 60 plus liters for adult. You can have a significant flow rates. The precision with the FiO2, even when you are going on higher flows, with the oxygen flows, you can adjust for an exact FiO2 that can be monitored as well. And usually one interface is required for all therapies. Like even when you go for a tracheostomy, high flow, you can the same tubings, only the area or the interface connecting has to be changed. It is comfortable and it is comfortable and it is sorry for the spelling mistake, it is unobstructive, and there is a tracheostomy option. You all might have seen there is a separate tubing for tracheostomy whenever the patients are put on spontaneous breathing. So the features of the commonly used Airvo 2, which is the common machine, that is why I've mentioned the trade name. So it is a US FDA, European CE approved machine, etc. And it is having a convenient oxygen delivery from 21 to 100%, and it is having an integrated humidifier, flow generator. No need for an external air compressor is not required. Simple controls. integrated oxygen mixing, inbuilt oxygen sensor, which will tell you what is the FiO2, no probes or external air supply required, and low weight, and it is portable. So this is very, very important. Just like in ventilator, you require an oxygen and you require an air, medical air, to mix that and deliver a particular FiO2. But here, you don't need an external air source, only oxygen is enough. So the indication for HFNC can be hypoxic respiratory failure, like in a pneumonia or ARDS, post-surgical patients with respiratory distress syndrome, and then weaning off from the mechanical ventilation. This is one area where we very commonly use HFNC nowadays. After extubation, you can keep the patient on HFNC with the proper humidification, proper temperature, where you can have an adequate toileting as well. And it can give a pressure support and a PEEP effect. Viral bronchitis in children, you can use. The pulmonary fibrosis patients or ILD patients, where you don't need a BiPAP support or a ventilatory support. The sepsis patient, onset of swine flu and other respiratory infections, mild to moderate pneumonia. When you are palliating the patient where you are not going for invasive ventilation, chest trauma, mild COPD and exacerbations of secretions, asthma, home oxygen therapy, especially for ILD, and bronchiectasis, especially, sorry for the spelling mistake. In bronchiectasis, again, because of the humidification and flow, you will be having better toileting. So one thing is, it can deliver up to 100% of oxygen, as we've already told, usually 21 to 25% in the room air, 5 to 10 liters oxygen, it is getting mixed. You can see it is a mixture. But here, when you are going for a nasal oxygen, you can see the complete, here the blue one is a normal air, 21%, but here the complete air is replaced by the oxygen what you are giving, or what is the precise humidified oxygen with the appropriate FiO2, or you can even keep the patient on 100% FiO2. And high flows of oxygen delivered comfortably through nasal cannula. You can see even up to 60 liters of flow, 100% of FiO2 can be comfortably given, and the patient can eat, drink, talk, communicate, sleep, etc. comfortably. Sometimes patient can have a feel of warmth, and maybe a sound or the flow may be a bit irritating, but patients are much comfortable than other NIV or the nasal mask, etc. Whether it is having a PEEP effect, this is the one which we discussed initially. So here you can see when the flows are increased, there will be the optimal humidity enables the comfortable delivery of high flows that results in the positive airway pressure throughout the respiratory cycle. You have an inspiratory and an expiratory cycle, and there is a direct relationship between the flow and the pressure. So how you increase the PEEP, you increase the flow, your PEEP will be more. So if you want to have a more PEEP, you have to give more flow. So this is the mean airway pressure. You can see here. With a flow rate of somewhere 40, you are getting a mean airway pressure of somewhere around 4. But when you go to 60, you can go up to 5 to 7, etc. This is the mean airway pressure, not the PEEP. And again, it can, because of the proper humidified air, it can have a better mucociliary clearance. It can keep the secretions mobile, moving secretion up to and out of the airway, and reducing the risk of respiratory infection. Whenever there is the proper toileting, the airway, the mucus obstruction can be minimized. So when should I see the effect of these high flow oxygen? So usually when the patient start tolerating an high flow oxygen in a distress situation, the heart rate will start coming down in 10 minutes. The respiratory rate will be reducing in 5 to 15 minutes. The oxygenation will be improving in 10 to 15 minutes. The patient's discomfort or dyspnea, breathing difficulty will reduce in 10 to 30 minutes. And the retraction or the usage of the other accessory muscles will reduce in half an hour. And the thoracoabdominal asynchrony, which you initially see, will settle in 30 minutes. So always see this chart, which is very important. Now you can the heart rate, respiratory rate, and oxygenation changes you can see immediately. In that, heart rate will be the one which you can see fast, but the dyspnea, the thoracoabdominal dysynchrony, accessory muscles, etc., will take almost half an hour. So don't expect all these changes immediately. You will have to wait up to half an hour to see these changes. So initially in 10 minutes itself, you can see the heart rate variation getting reduced. I mean, the heart rate getting reduced, or the variation will, the heart rate increase will start settling. The respiratory rate will come down by about 15 minutes. Again, oxygenation also will start improving 10 to 15 minutes. So immediately after putting an HFNC, even if SpO2 is slightly low, you can wait for up to 15 minutes by the time the SpO2 will improve. So how the flow can predict the FiO2? This is again very important. This is the high flow nasal cannula. So whenever you go high on the flow, again the mean FiO2 delivered will be less. So here you can see the mean FiO2 delivered will be less, or for a given flow somewhere around 50, 60, etc., your oxygen requirement will be more. That is why during COVID season, etc., where we have oxygen, the deficiency or oxygen, the supply was limited, so we always tend to keep the flow somewhere around 30 to 40 or even around 30, so that you can get a predicted FiO2 with a minimum oxygen possible. So whenever you go higher on flows, your oxygen requirement also will be more. So this is one case, one clinical situation. A patient was ventilated, 2 weeks later extubated to HFNC. So how will you wean from the HFNC? This is a usual situation which we all will come across. So one thing, you can slightly reduce on flow, then you can decrease on FiO2, or sometimes you can decrease both simultaneously or decrease both sequentially. So which one will you go for if you have all these options? So obviously you will have to come down on flow, and then you reduce on FiO2. Whenever you reach somewhere around 30 FiO2 with a reasonably low flow, somewhere around 25 to 30, then we can try other devices. So the indications for weaning can be mild or no increased work of breathing. The heart rate, respiratory rate, etc., are getting normalized, not absolutely normal. Saturation is always maintained at more than 92% with the FiO2 somewhere around less than 40. And the first gradually you wean FiO2 by 10% increments, ideally aiming for 21% to maintain SpO2 of 92%. This is the ideal situation, which may not be possible always. So what we usually do is, like when the FiO2 is gradually reduced and when it reaches somewhere around say 30%, etc., you can switch over to mask or nasal cannula, then can be maintained like that. One needing less than 40% of FiO2 with minimal or increased work of breathing, then you can try reducing the flow rate. So first you reduce FiO2. Once you reach somewhere around 40 or even less, then you can try reducing the flow. So the physiological outcome are, one thing is reduced respiratory rate. So as I've already told, you can have reduced respiratory rate and increased tidal volume and reduced respiratory rate, and reduces the PaCO2 and respiratory rate. And to somewhere up to an extent, it can be used in type respiratory failure as well, where you can have you can get a carbon dioxide reduction, but the reduction will be minimal compared to NIV. And again, here you should not go very high on FiO2. FiO2 should be titrated to an SpO2 of somewhere around 88 to 90%. When the patient is having an improved oxygenation, so it is delivered the prescribed FiO2 as we have discussed. Improved oxygenation on patients with respiratory distress, improved oxygenation definitely the lower the oxygen therapy requirement, improved oxygenation compared to face mask oxygen therapy, and improved oxygenation during bronchoscopy and recovery. This is also very, very important. During a bronchoscopy also, we can put the like 100% FiO2, etc., and then do a bronchoscopy where your hypoxic episodes will be minimal. And you can reduce the work of breathing because of positive airway pressure, which is associated with improved oxygenation, reduced work of breathing, reduced supraclavicular retraction, and reduced thoracoabdominal synchrony, asynchrony, which we have already described. It can also increase end expiratory lung volume because of the increase in airway pressure was significantly correlated with increase in lung volume. So to summarize, there are differentiated mechanisms like respiratory support, reduction in the dead space, dynamic positive airway pressure, supplemental oxygenation, airway hydration in patient comfort. The physiological outcomes will be reduced respiratory rate, increased end expiratory lung volume, increased tidal volume, reduced work of breathing, improved oxygenation and improved mucus clearance, which is very important. The clinical outcome will be reduced escalation of care, improved patient comfort and compliance, improved symptomatic relief and reduced exacerbation days. So obviously, which lead on to reduced length of stay, reduced cost of care, and improved patient care and outcomes. So the wide range of the delivered flows are there. There are different studies in ARDS, like a post-cardiac surgery. Then you have the different studies on do not intubate the patient with hypoxemic respiratory distress and acute respiratory failure. So here you can see whenever there is a ARDS or a hypoxic event, you will have to definitely keep the flow slightly high because this is the flow which is giving the PEEP effect. But other situations where you can keep a flow somewhere around 30 to 35. And in situations like the bronchiectasis, COPD, etc., you don't need very high flow. You need only like a minimal flow. Here, basically, you are using for like a toileting or better hydration and clearance of secretions. So it can be used in invasive ventilation weaning, rest therapy and weaning. So this rest therapy concept is also very important during NIV. Like whenever the patient is on NIV, he may not be able to breathe, eat, etc. So in between, you can remove the NIV mask, put them on HFNC. They can again clean the mouth. They can eat something. They can drink something. So this is called the rest therapy. And current run rate of OptiFlow interference, we only address 1% of the total market. That was the old figures. Now it is again increased. So the low level pressure delivery in this one, you can see the continuous flows of gas delivered to the nasal the nose by OptiFlow generated lower level pressure, and mean airway pressure was significantly higher with OptiFlow. You can see the normal oxygen, the face mask closed. When with an OptiFlow of 35 liters, you can see the range up to 5, or the airway pressure up to the 5, or you can get a PEEP like that. So this is again mouth open and mouth closed. When the mouth is closed, again with a 60 flow, etc., you can keep a PEEP up to 5 to 7. So the HFNC can be used for humidity, where the humidity will be useful for mucociliary clearance and the comfort. The flow will be basically for oxygen, accurate oxygen delivery, then washout of anatomical dead space, and low level pressure support or PEEP effect. So the traditional oxygen therapy were giving low flow nasal prongs, the face mask, the Venturi, etc. And now with this newer device, you can have a precise level of FiO2, etc. So what we are trying to achieve, we are relieving the hypoxia, deliver the desired oxygen concentration by maintaining the comfort and compliance, and reduce the potential escalation of therapy. Like it can prevent the patient going for intubation and other invasive procedures. So what are some of your challenges? Large range of products which is more effective, you don't know. Sometimes the patient still have a breathing difficulty. The patient compliance may not be that good. Maintaining secretion clearance and patient airway, providing adequate humidification, inability to deliver desired oxygen concentration, maintaining patient comfort, patient desire to eat, drink, sleep, etc. can be done, and progression to more intensive therapy sometimes may be required. So the challenges and solutions are like it can deliver warm, humidified oxygen. It's more comfortable and tolerated. It is simple to set up, where you have to set up only flow. Then the FiO2 can be adjusted based on the flow meter, and it can deliver accurate FiO2. So rather than using these different devices, now we have these the high flow nasal oxygen, which again is a much better option than going for other issues. So here again, when you compare the nasal cannula, face masks, etc., it is having a better mucociliary clearance. Comfort-wise, it is as comparable with a nasal cannula. It can have an accurate oxygen delivery compared to other devices. Washout of dead space is possible only with very high flow from a HFNC cannula, and it can give a pressure support and a PEEP effect as well. So the traditional respiratory care, the continuum are humidity therapy, low flow oxygen, face mask, then NIV and invasive ventilation. So now we have, along with the NIV, we have this OptiFlow HFNC before invasive ventilation. And after the extubation also, you can use these OptiFlow. So the high flow is but distinctly different from ventilatory assistance compared to CPAP. Here you can see the CPAP of 5, a jet ventilation 15 liters, and again 15 liters a median cannula and control. But here you can see when the CPAP effect. So basically, high flow oxygen on ventilation during wakes up and sleep. Nasal high flow is a distinctly different from ventilatory assistance compared to CPAP. So the 10 healthy volunteers recruited, 21 oxygen via the blender delivered, flows 0 to 60, and humidification, pharyngeal pressures measured. And here you can see the mouth open and mouth close. So here in mouth close with up to 60 liters flow, which I've already told, you can achieve a PEEP somewhere around 5 to 8. So if you want a PEEP effect, what we can do is keep the flow on the higher side, somewhere around 60, where you can achieve a PEEP somewhere between 5 to 8. So this is again the requirement of intubation and again the requirement for ventilatory support. These both can be reduced as per this study using high flow nasal cannula. So this is again a randomized controlled trial like at versus the HFNC versus standard oxygen. So here again HFNC at 50 ml, 50 liters on 30% oxygen versus standard oxygen therapy, nasal cannula or mask, and it is titrated over 2 hours. So in conclusion, in this study, the use of high flow cannula was associated with reduction in respiratory rate, improvement in self-rated dyspnea. The dyspnea is rated by a number or a picture, etc., and fewer patients require escalation of therapy. So this is another study which is published in NEJM in 2015 France study, which again showed reduced mortality and reduced escalation of the care. In this study, a 23-center study comparing the nasal high flow to use of non-repeated mask and NIV as a primary treatment. So which again resulted in the high flow significantly reduced the mortality, reduced the need for intubation, and significant increase in ventilatory free days. This is another study again. It was showing non-inferiority to NIV. So here again, it is used as a NIV rest therapy. We have already told what is this NIV the rest therapy. You keep the patient on NIV. In between, you give rest. You can keep the patient more on like HFNC in this study. So the oxygenation improved when the patients were switched from standard oxygen therapy to the HFNC in between these NIV usages. And the heart rate and respiratory rate significantly decreased after the initiation of these HFNC during the rest phase. So the key mechanisms and benefits of HFNC are mucociliary clearance, comfort, etc. Because of the flow, we have washout of anatomical dead space, accurate oxygen delivery, and low level pressure. The clinical outcomes are the comfort, the therapy success, improved lung volumes, etc., which finally lead on to a reduction in escalation of care, increased patient and caregiver satisfaction, reduced length of stay, and reduced cost. So I was just going through the basic concepts about the ventilatory support, and there is again you can download a mobile app where you can see the OptiFlow. If you see the OptiFlow app, in that app you can see like how to make the settings, etc. Or during our the workshop, we can show you how to titrate, use, make different changes for HFNC. And regarding the cannula usage, only the interface, which is coming directly in contact with the patient, we use for single usage. The other part of the circuit, we usually ETO sterilize and reuse that. And for the humidification, we can use the distilled water as well. And there are special interface for tracheostomy, and all the machines are having now adult mode and a pediatric mode. So always careful, like when you are using these machines for adult and pediatric, when you are interchangingly use, you have to switch over from adult mode to a pediatric mode. So thank you so much, and we'll take questions now.
Thanks a lot for that wonderful session, sir. So we have two queries from Dr. Gauri. What are the contraindications for HFNC, sir?
Again, there is no specific contraindication like for HFNC, but when the patient is having a low sensorium, and when it is a relative contraindication, like the chances of aspiration will be there. So avoid HFNC in that situation, or depending on the level of care you are aiming at. Suppose if it is a palliative care, definitely you can go ahead. Otherwise, definitely you will have to go for invasive ventilation. Same way during the type 1 respiratory failure or ARDS, when your oxygen requirement is too high, like especially when it is more than 60%, etc. Again, the recruitment effect, etc. Recruitment effect by the HFNC will be very minimal. So don't keep on HFNC for quite long time. You know the ROX index. So based on the ROX index, you can see whether the patient is tolerating or not. If the ROX index is coming below 5, don't keep the patient on 100% FiO2. Look at saturation and see that the patient is comfortable. Please don't do that. That is a big lesson we all learned during COVID also. It can have something called a self-inflicted lung injury. So don't do that in that situation. You have to appropriate intubation at the required time is always very, very essential.
Probably that answers the next question also, I guess, sir. The next question was from Dr. Muthukumar. When should we change over to invasive mode in ARDS after HFN mode?
I've already told, like you can go ahead with a ROX index, and when the ROX index is coming below 5, that is an indication. The same way you look at the FiO2 requirement also. Whenever the FiO2 requirement is going more than 50, etc., that again and again the patient is showing a deteriorating trend, like I've already shown. Even after half an hour, your oxygenation is not improving. The patient is still dyspneic, the tachycardic, etc. That is again an indication to go for an invasive mechanical ventilation.
Yes, sir. Thanks a lot, sir. I have personal queries, sir. Some of the ventilators nowadays have high flow oxygen, and I mean invasive ventilator. How about the usage from your side, sir? Your experience, sir?
I've seen only the demonstration with that. There are many Indian HFNC machines also, which is very cheaper. But again, the multiple use of circuit, the precision in the flow, FiO2, etc. As far as my experience is concerned, it is a bit difficult. The same with whenever you go with this high flow, either through now some of the NIV machines are also having these options. So definitely, I'm not comfortable, or the controls are not so precise like the regular HFNC machine, like the RO2, what we all are using nowadays.
Yes, sir. So one more question, sir, from Dr. Samudran. How useful in type 2 respiratory failure?
Type 2 respiratory failure, I've already told, usually it is not very effective, but when you keep an FiO2 on low side with a minimal flow, like as I've already told, it is having some pressure support effect also. It can be tried, but whenever a patient is having a type 2 respiratory failure, NIV is always preferred over HFNC. There is no doubt about that.
Yes, sir. Hope that's it. We don't have any more questions in chat box, sir. Once again, on behalf of our team, we thank you for sharing your time, sir. Thanks a lot for joining us, sir.
Thank you.
Thank you, sir. So we come to the end of the day. Tomorrow we go for the final day. It will be on ECMO. So it will be sessions like VA ECMO, VV ECMO, starting with the introduction to ECMO and its hardware and evolution of ECMO. We will see you back tomorrow by 7 p.m. Thanks a lot for joining us. Thank you.